So welcome. Hello, good afternoon now. My name is Katrina Wilson. I am a principal advisor working for Eastern Academic Health Science Network, and more recently have been supporting the COVID Oximetry work that has been led through the Eastern region with colleagues on the call and also colleagues further around. I'll just let you see that I am a real person, and hello and welcome. I have a face for radio, so I was kind of sitting in the background, but thank you. Hopefully today we've got a packed agenda, so I am going to rattle through with support from colleagues, but we are basically going to review. It's been an interesting few months. You have an agenda there which hopefully we will stick to, and thank you very much today for colleagues and speakers for their time. We do have people that need to leave by 1 o'clock, so we are going to hopefully keep very much to time and give the space today over to colleagues that have been working frontline and experiencing this and evolving their knowledge, and also to presenters who are providing and supporting those digital platforms for remote monitoring that some of us didn't know much about a few months ago, are very rapidly learning much more about, and hopefully we will review that as we go through the day. As has already been mentioned, the meeting is being recorded, and the recording will be available after today on the Eastern Academic Health Science Network website, and also on the NHS Futures website for those of you that have access to that. But would recommend, there will be a point later on, recommend if you don't yet have Futures access, those of you that are able to access this, I would recommend that we do. So cracking on, I've done a few slides just very quickly to review where we've been, where we've come from. The Academic Health Science Networks, there's 15 of us across the country, and we have been supporting the delivery of COVID oximetry initially as pulse oximetry at home work programme, and then latterly for us in the Eastern region from November, and then sort of Christmas time, the week before Christmas, in relation to COVID virtual wards and building on discussions around COVID virtual hospitals. It is a very, as those that hopefully are on the call will agree, a very live, very agile conversation. We are learning on the job and very much picking up national and international coverage for how this is working, and we're now reaching out globally to learn from other parts of the globe to understand what they've been doing and how they've already approached this, not at a time of crisis. So I think it's fair to say it's a very pertinent time to be talking about remote monitoring. Moving on. So again, just very quickly, the journey over time for us in the Eastern region, obviously we extended this programme and were asked to extend this programme latterly during last year as the cases and numbers increased. Unfortunately, colleagues and numbers up in the north were sort of earlier on, and so they very much started and led the charge for this work. And that has been, to be fair, great for us because we have begged, borrowed and stealed a lot of work and adapted it locally, which has been super helpful, but also a very large willingness of the local ecosystem partners to work together, some in different ways, some in new ways, and that's been really great to see. So moving on, as it says there, a lot of us have now got used to, if we weren't used to RAG rating charts before, red, amber and green is the way to go. So lots of algorithms, lots of flow charts, bringing in new cohorts of patients as we've gone along, which I think has been, you know, super helpful, always with the patient and staff at the centre, what can be delivered safely, what can be, you know, ultimately a quality service that can support the wider system. I think it's fair to say that at the start of this, certainly within the Eastern region, there was some very sort of strong concerns around language and clarification of what people meant in relation to oximetry, COVID oximetry at home and primary care-led models versus the evolving and expansion into COVID virtual wards, secondary care-led models, but again, very much responding to systems, bearing in mind their workforce, their redeployed workforce, and all of the factors that we've been sort of sleeping and breathing for the last number of months. So the remote monitoring opportunity that we see, and the ranges of opportunities in relation to what can be delivered from one end of the spectrum, from a pencil and paper, all the way through to, you know, a very multi-complex hub and spoke, partner-led, you know, ICS system-wide potential is quite massive. And then obviously, as we've, again, as I say, been learning on the job, some of us have more experience, and again we will hear about that in a very quick moment, around what we want the technology to do. So some of us, you know, as members of the general public who happen to have a job maybe within the NHS or maybe within a healthcare profession or company, have very much been, okay, so I have a smartphone, I know it can do this and I can look the weather up, but actually it can do so much more. And the technology is there waiting in the wings. It really needs to have an understanding grown, so supporting that shared language, but also the possibility of, you know, it is about what is possible and isn't miles away, it isn't 5 years away, it's actually here now, that can support patient care, safe delivery and evolving of services. So now, if I may, I'm going to introduce Dr. Andrew Barlow, who will take us through the next part of our talk.
Thank you, Katrina. Hopefully you can hear me okay. Hello, everybody. I'd like to show you the art of the possible and show you the evolution of our experience, which started in March 2020. I'm a respiratory consultant and divisional director for medicine at West Herts, and then more recently, I've been asked to be the clinical lead for the region for virtual hospitals and oximetry at home. I must acknowledge a number of colleagues, Matt Knight, who's on sabbatical at the moment, who was the co-designer of the original platform with me. But I want to shout out Alex Newland-Smith, who's our senior physiologist, who is the very much the operational lead for our service. And the go-to person for anything to do with the technicalities of onboarding people, monitoring them, and ensuring that patient care is of high quality. Next slide, please. Quick conflicts of interest. If I mention anything, it is circumstantial. Expediency was the main driver of our service and how it evolved. Yes, we did use certain tech platforms, and I will of course mention those, but that doesn't mean anything more than we have experience of that, and please don't take it in any other way. But suffice to say, I'm a massive fan of technology in principle, and it has supported our service and enabled it to grow. Next slide, please. So how did it all start? Kitchen table on the 9th of May, Matt and I sat down with a laptop and an Excel spreadsheet, and we designed the principle of the COVID virtual hospital, having seen the newsreels coming out of Italy, particularly, which were pretty horrific actually, in terms of the volume of patients that we considered were coming our way. 14th of May, we onboarded the first patient in the West Herts virtual. Sorry, 14th of March, not May. That's a typo. We onboarded the first patient. In June, we got a leader on the BMJ, which name checked our service, along with one from North Manchester. And just to show you how it evolved, from there we saw a summary paper by Naomi Phillips Group at UCL, and that was in September, and with drafts coming through early October. NICE finally got on the act in November 2020, and then finally some details and programs from NHS England came through in January 21. So it's taken nearly a year to formalise the program. But the point of showing this was that this is all about people, and you can do it at speed. And if the system is agile and adaptable, then actually you can achieve a lot with just people. But really, the technology should be the enabler. and enable you and bring some assurance and enable you to grow. Next slide, please. So what do you need setting up a virtual hospital? Well, these are all fairly obvious, I hope. You need a primary driver and a purpose. You need to identify a clear target group and design your pathways according to the clinical needs of that group. I don't believe that a generic virtual hospital per se is the right way to go. You've got to have the right staff and skill sets, and then you start thinking about the resources, including the tech and the monitoring. The pathways are crucial and they have to be patient-centered. And I think it's really important to take that on board and embrace that principle. Put the patient at the heart of everything you do in the pathway, and then bring in the resources and the interventions at the right moments with the right people intervening. You need to plan escalation routes because things don't go right all the time. And just a common sense rider here, which is, technology does not replace human intervention. It should work hand in hand. Next slide. So as mentioned just now, March 14th, the first patient was on board, and you can see the volume of patient referrals by day in wave 1 for West Herts. I label the kind of the next 3 months as the difficult teenage years as we got to grips with information governance, migrated our platform from Excel onto an Infoflex platform, which is where it rests now. And really that's enabled us to put a large volume of patients through, and we've well exceeded 4,000 patients now with the wave 2 patients added through. Next slide, please. This was our original patient pathway in March. So this was before any guidelines, before anything came out from NICE or any national body. We had to guess in terms of the entry criteria. We designed 2 routes within the virtual hospital, a low risk and a high risk. We used the European data to identify what we thought was a clinical low risk patient and a high risk patient. The pathway for both groups was 14 days, and dependent on your clinical risk, you either had a light touch intervention or what I would say was a much heavier touch intervention with nearly daily calling. In the first instance, it was just supported by oximetry, and there was no tech involved, but we clearly evolved that. Next slide, please. So this is data from wave 1 from our virtual hospital. This is a paper which is still being reviewed by the BMJ. It's available on MedRx IV, and it shows how we managed all these patients, approximately 900, evenly split between the method of route into the virtual hospital. So it was half the patients came directly from ED and half were ward discharges. The reason for me to just highlight the direct from ED group is that a lot of people said, well, surely you onboarded a lot of people that actually didn't need monitoring or management. But you will all note that actually this is a multi-morbid group. This was a patient group that had carried significant clinical problems. I particularly want to highlight some of the outcomes for this group, and in particular the readmission rate. You'll all be aware of a BMJ paper approximately 6 weeks ago, which looked at readmission rates nationally for COVID, which was in excess of 30%. And we had an 8% readmission rate on wave 1, and it's significantly lower than that on wave 2. We believe this is a direct effect of the patient's management through the virtual platform. Next slide, please. Wave 1 entry criteria was very much guesswork. And you won't be surprised to hear that we've evolved that further. So next slide. And and this is our paper in thorax for next month. We've developed a scoring system, a 5-point scoring system, which is predictive of mortality, and that allows very clear decision making at the front door. Now we cut it at a source score of 1 or less to go into the virtual hospital. We could have cut it at 2 or less, but we were being quite risk averse at that stage. But you can see that the mortality rises quite significantly after a score of 2 and above. And so we use the source score, and it's embedded in our protocols for that front door decision making. But it enables some really nice protocols to be built and embedded into tech platforms. Next slide, please. So using technology for us, as I said, has been a major time saver, and you can see the kind of volumes of patients we've had to deal with, and so you know, that's where it's come into its own. I wouldn't sit here and advocate one particular system. You need to develop whatever your expertise is locally, and make it right for you. But as I've said before, you have to put the patient at the centre of the equation, and it has to be clinically safe. If the technology doesn't help, dump it. So what I'm showing here is the referral form we've developed for the Infoflex platform. Infoflex is made by a company called Sims. They're based in Watford. It's actually a ubiquitous system across the NHS, and it runs most of our services in the hospital, admission summaries, endoscopy reports, etc. So this form is the form that the junior doctor fills in A&E if they've got a low source score of 1 or less. Clinical information goes in. We can identify whether we're going to identify that patient as a Medopad user. And you can see there's in the centre of the referral, there's an opportunity to say Medopad yes or no, and we use Medopad as the monitoring platform for patients if they could accommodate and use that technology. Not everybody could, but a significant proportion did. And so you can see it's very nice. And this is a simple database at its heart, and it allows data collection and analysis. You can see at the bottom there's a recent add-on, and this is for the discharge patients. So we're now discharging patients with oxygen, and it's an integrated pathway, bringing in our colleagues in the community, specialist nurses, to provide dual care program for these patients. Next slide, please. This is just to say that you remember that first pathway. In essence, the pathway on the left and the right is exactly as it was when I showed you on the earlier slide. The central pathway is now the adapted pathway for patients that can accommodate and use the Medopad technology. And if we go to the next slide, please. What we found actually is that it has reduced the frequency of required calls to this patient group, because the patients have an opportunity to identify how they're feeling and upload their physiologic data. The consultants reviewing that data can see all of it on a single panel, and actually once it's been reviewed, the patient can see that is the case. And the feedback from the patient group has been very good. They like the fact that they can identify that a clinician has seen their data and that they're happy. We've picked up some early deteriorating patients, especially in this happy hypoxia group, where they didn't actually feel that bad, but their oximetry was suggestive of deterioration. And overall, we think it saved a significant amount of clinical time, which you'll see was very important when we go to the next slide. I'm showing you this because it's data from Wave 2. And if you just look at the top line, these are monthly totals of referrals into the virtual hospital. And in January, we're just under 1,000 referrals into the virtual hospital. And I think without the additional technology that we've built in during the summer months when it was quieter, I think we would have struggled with these sorts of volumes, because we've now put through in excess of 4,000 patients through the virtual hospital. And the other reason for showing you this slide is it's a much more complex route in now, not just from ward discharges and A&E, but we actually embrace the principle that we should look after our own. And so any staff member testing positive was automatically onboarded into the virtual hospital. And we felt that was the right thing to do. And you can see the kind of numbers that we looked after in terms of staff as well. And without the technology, that would have been very difficult. So what about the future? Well, we're already looking at possibilities of real-time continuous monitoring, and one particular manufacturer is noted there, but obviously there are others. At West Herts, we've piloted virtual post-taking, and that's on Microsoft Teams type platform. And that is where the specialist is at home, but with access to all the clinical information that you would normally be able to see if you were in the ward itself. And we're having post-take conversations with junior doctors, and if need be, the patients themselves, reviewing results, and in effect providing a virtual ward round for emergency admissions. We're aware of other colleagues in the locality using point-of-care ultrasound, and I think that may be a really interesting innovation to look at in the future, because you can live link the images to specialists in a reviewing hospital, and GP hubs can provide this kind of technology potentially. And as I think Katrina mentioned, we're now turning our eyes to other disease entities. We onboarded our first COPD patients yesterday. We had 2 trial patients, one step up and one step down. They are now being monitored at home, and heart failure and COPD will be are formally supported by our ICS, and I think there'll be formal platforms and programs for both of those entities within the next 6 to 8 weeks, I hope. So yeah, and this, I mean, I'm not going to talk over this, but this has been a real journey in terms of learning on the job, but it has rather catapulted a lowly district general hospital into the spotlight, and generated some very exciting research opportunities. And as mentioned, we've published in thorax already. We hope to have our virtual hospital data in BMJ once we can overcome the reviewers' concerns, and there are a number of other publications on their way. So it's been a very exciting journey, but tech has been at the heart of it.
That's great, and thank you so much. And we'll rapidly now move. May I introduce Breda O'Brien, who's the Deputy Director of Digital Health at NHS X, please. Thank you very much.
Thanks, Katrina, and thanks, Andy. I think it's really appropriate to say that West Herts started this, we're really at the starting point of all of this, and influenced it very significantly. So a huge congratulations to the team for that, but also really interesting hearing about your plans for the future. So you haven't stood still, and great to see tech at the heart of everything you're doing. Next, I'm going to take you through our national programme quite quickly, of which some of the work we've supported relates to, and also through some specific work we did then as part of what we refer to COVID Wave 2. So influenced significantly by the work at West Herts and in North West London in Wave 1, we called our regional scale programme, we focused it on a COVID response, and we asked people the regions to respond to us in a bid for money to say, what can you do to help with remote monitoring, including possibilities in care homes, in people's own homes. Basically, it was any response, but also included outpatients. So we allocated 10.5 million, equally distributed across 7 regions, and 24 projects were approved and moved forward. And on the right, you can see some of the themes. Home monitoring obviously features quite heavily, but we know that some of the virtual ward work, reaches into care homes. It's covered under long-term condition management. So it's not it's hard to categorise exactly in terms of all the programmes. Next slide, please. So our approach, our main ethos of the programme is to support people at home and to focus on accelerating remote monitoring across England, building on some of the work that Andy and others have spoken about nationally. As I said, regional scale plans, 7 regions all working on different projects, and I will outline those in a moment. But also supported by something we call our National Innovation Collaborative, so working in partnership with AHSN colleagues and really trying to focus how we can rapidly share learning and avoid people duplicating effort. So taking the learning from West Herts, really sharing that with everybody nationally so they could learn. And this was also supported obviously by lots of other pieces of work that were going on, including the AHSN patient safety work. Did some work on procurement, and also I've just on the previous slide there were a couple of other areas of focus which it's linked to our joining up care work. So 11,000 iPads distributed to care homes, which enables people to also access technology whilst also supporting them to keep in touch with loved ones. Some clinical communication tools. It's linked to the NHS at home work with NHS EI, and because we are a learning organisation, obviously we're doing an objective evaluation of this whole approach, and outpatient pathways I've already mentioned. Next slide. I'm not going to dwell on this because it's a busy slide, but the slides will be available, I'm assuming. This is just outlining the astute people amongst you will count on those 23 projects, and that's just because in London there's 4 care home projects. But this is just outlining where people said they were going to focus at the beginning. So this is in September, August, September time. And I was delighted that one of the things that appeared in every region was working care homes, because at that point, if we can cast our minds back, that was an area of very sad focus really in the media. But lots of work on virtual wards as well and long-term condition management. Next slide, please. And this is just outlining some of the platform suppliers that the regions have chosen to work with. This is not an exhaustive list. This is the ones that we have had requests to fund. So there's lots of really good work going on with these innovators in other areas, but also people that aren't mentioned here. So this is not an exhaustive list. And I would say that the support from the innovator community generally has been superb. So we've really made huge strides in progressing here. Next slide, please. And actually, just before I move off the Innovation Collaborative more broadly, at the last count at the end of January, we were supporting 34,000 patients nationally through this work, through the product set that I've just shown on the previous slide. But also in Wave 2, so in late December, we were asked what support we could give to the evolving clinical models for COVID Oximetry at home and COVID virtual wards. So working very closely with people like Matt and Ida Kim, and obviously Matthew and others influenced through their clinical groupings as well. And with the Patient Safety Collaborative, we offered to support up to 50 sites who wanted to use a tech-enabled model. At that point, predominantly for COVID Oximetry at home, but we were also happy at that point to support virtual wards. And I'm really pleased to say not only did we reach the support to 80 or to 50, but we now are at 84 sites. And a site can be a CCG or an acute trust providing this service. So we've got 84 organisations across the country with technology-enabled services, and a few more to go live before the end of the year. So this has grown phenomenally, and the interest, if we were continuing to support, we would continue to have interest and requests for money to support it. Next slide, please. This, I just wanted to show, I mentioned that we've got about 34,000 patients engaging through remote monitoring, and that's a cumulative figure. But actually, I realise, sorry, this slide is slightly out of date, so it is 34,000 that are engaging as a cumulative number. But we do have a bit of gap between the capacity, so the opportunities it's created, and the utilisation, and that will be a focus. Some of that for very good reason. We may have the capacity created to support a complete care home, but not every resident needs it at a point in time. Some of it is still down to our people and process. So transformation using technology is absolutely people, process and technology, and we need to get the balance of all those right. So that's ongoing work, but really good uptake, as you can see, across the country. Next slide, please. I'm not going to dwell on this. It was really just to show the activity we've had through the Innovation Collaborative and the learning events. There's a really big appetite amongst people to share and learn from each other. And that is something, our AHSN network colleagues have been really supportive with and will continue. Next slide. So next steps. So our ambition now is to reach 300,000 patients in 2021-22. We are continuing to support the regions with implementation funding. And Helen will speak to that next about how that looks for the East of England. Our focus is on 4 areas this year. Last year was a bit more open, and it speaks to some of what Andy's been talking about. So long-term condition management and virtual wards, because we recognise for some patients they don't need active monitoring. They could be managed in primary care. We want people to be enabled to self-care. But then the virtual wards is obviously a bit more intensive in terms of the oversight and management. Continue to support care homes, moving into a new area, which is mental health, and particularly a very specific focus on annual physical health checks, because obviously this is a very vulnerable group. And it was interesting, Andy, to see the volume of patients who had comorbidity for mental health in your slides earlier. And then we have still left one locally determined priority, so that we are allowing and supporting the regions to be innovative and think outside of these other 3 areas. We've now confirmed funding for the next 6 months for the regions, and I think this year again, it's moving from what last year was perhaps more tactical and reactive to the more strategic fit and how systems, the connectivity question becomes really important, because what we're hearing loud and clear, we want to collect information once and use it many times. And then a focus on improvement enabled by technology to support optimization. So again, really capitalising on what we've done this year, but recognising it was rapid and that we do need to do some optimisation work. And I will finish by saying, I think, the aspirations that Andy, you've set out really resonate. They're what we're hearing nationally. They're what we're hearing from NHSE and I colleagues at a senior level in terms of this is a really important part of our recovery phase, and it's seen as not something that was for COVID, but something that has opportunity for the future. And I'm just handing over to Helen for the East of England view.
Hi there, yeah, so I'm based in NHS England regional team. So just to build on what Breed has said there, there is funding available for 21-22, and that's open for bids now. The guidance and all the information that's required has already been circulated to your local STP, CCG leads for onward distribution. If you need to get hold of that information, if you contact them directly, if you're not quite clear who that might be, by all means contact the mailbox at the bottom of the slide there and we'll be able to assist you. In terms of the allocation for the East region, there's about 2.3 million available to support initiatives in each of those focus areas that Breed spoke about, with the intention being that 33,000 patients will benefit from those services as a result. As was mentioned, this is for implementation funding, so this is not to fund kit itself. This is actually around the redesign of pathways and setting up these services. And there's the expectation that this will have a strategic focus. So each of the bids is expected to be on behalf of an STP ICS rather than individual organisation, to make sure we have that holistic view. And then just finally, conscious of time, the deadline for the bids in from each of the STPs is Friday the 19th of March to that mailbox, again, that's on the slide there.
That's great. Thank you both so much, Breed and Helen. That's marvellous. And then in the spirit of moving on for time, may I introduce Jonathan Gledhill, who is the Head of Healthcare from Humour, previously Medopad. Thank you.
Thanks, Katrina, and good afternoon all. Yes, I was going to add that, yes, we were formerly known as Medopad. We recently rebranded to Humour, just in case there's any confusion in the audience. And really, I just want to take you all through a bit of an overview of the company, what we can offer, and some of the experience we've had with our virtual ward and remote monitoring deployments, some of which obviously Andy has touched on, our work with West Hertfordshire. In terms of Humour itself, we're a global company. We're headquartered in the UK, but have operations both here in the UK, in Germany, Italy, China, and the US. And we have a growing team of about 150 people, of which there's a dedicated clinical and research focus within that. And really, our offering centres around offering technology to enable better care and better research. And we do that via our software platform through 3 areas, really: offering remote patient monitoring or virtual ward technology. We also support clinical trials and real-world evidence collection, as well as supporting population and predictive health with various risk scores and algorithms that we develop. We have an active work with partners, obviously working closely with healthcare providers, and in particular the NHS here in the UK, where we're operating with over 20 NHS organisations. But we also have active research collaborations with a number of academic partners, of which you can see a few of the logos there: Cambridge, Stanford, Johns Hopkins. We also have very active partnerships and collaborations with the life science community, the medical device and pharma sector, that often work with us in collaboration with other healthcare providers. From a regulatory point of view, we satisfy all of the credentials for software as a medical device. We're MHRA CE marked Class 1 medical device. We're also one of the approved suppliers through the NHSX setup framework, the DPS Spark, and so can have passed through a number of rigorous tests to get onto that framework. Next slide, please. In terms of our platform, basically it's a software solution that allows connectivity between patients and healthcare providers to allow virtual or remote care. We do that through two angles. There's the smartphone app that a patient can download from the Apple Store or Google Play. It's disease agnostic, it's configurable to multiple pathways. We have a library of data collection modules that can be selected for a vast number of pathways and therapy areas. So it's disease agnostic. It's also device agnostic. We can connect to a number of Bluetooth devices. We also support manual entry of data from vital signs devices, so can support a full range of medical devices, and none of our integrated devices are proprietary in any way. That we work with third parties for that. The app also provides, in addition to data collection such as vital signs, symptoms, questions, videos, step count, etc., it also provides a learn section to provide education to the patient to enable self-management and further awareness of their condition. And all of that data that's collected through that patient app is then transferred in near real time to a web-based clinician dashboard, which provides clinical teams with access to all of the data patients submit, provides an easy mechanism for them to visualize it and gain insight. Importantly, it provides rules-based flagging, so red, amber, green statuses for the patient, and allows telemedicine video consultation directly from the platform to the patient to be opened at any point should a clinical team member feel the need to get more information or simply connect with a patient directly. We also have the ability to export data in a number of formats to allow onward research or indeed import into other systems such as EHRs. And I just want to move on to the next slide, which is to cover a few examples of how we've used our platform and worked with NHS and other organisations. I would just add that these are a snapshot of some of our work, and that our platform can be configured to multiple other disease areas beyond those highlighted here. In terms of the COVID work, as Andy mentioned, we've worked very closely with West Hertfordshire and North West London to launch COVID virtual wards back in the first wave of April to support managing patients within both primary and secondary care. We're now live with over 13 NHS sites across primary and secondary care. Some of that work supported through NHSX and the great work of that team. We've also expanded to support Germany in a national deployment for COVID remote monitoring and virtual wards, and that's across 3 federal states already and expanding rapidly. We've also moved to support some of the Middle East. They're interested in supporting high-risk patients with cardiovascular disease and diabetes as part of the COVID response. So we have a very active presence in supporting the COVID pandemic, and that's branching out into other respiratory illnesses as well. In terms of our other work, we've also done some work with supporting surgery backlog, which is obviously a downstream consequence of the COVID pandemic. We worked with Smith & Nephew to support orthopedic procedures pre and post-operatively, and also to provide remote monitoring for the optimization and prioritization of cardiac wait lists at the Royal Brompton and Harefield, amongst others. Next slide, please. We also, in addition to sort of the episodic care, we also support chronic disease management. We have a live programme with North West London and Discover Now looking at diabetes, which is expanding into multiple sites for type 2 diabetes, monitoring them more frequently and also enabling the data to support improved pathways. We also have a very active set of work in cardiology, again working with the Royal Brompton in heart failure and congenital heart disease. We've had a project with Chelsea and Westminster on the test beds, and also working with a couple of health boards in Wales to support heart failure remote monitoring. And I would say, again, these are a snapshot. We can support hypertension, asthma, COPD, amongst other conditions and comorbid patient groups as well. And final slide, just to touch on some of the experience and outcomes we've seen. Andy actually has touched on some of these. We achieved some of these outcomes in collaboration with Andy and the wonderful team at West Herts. What we've seen from the deployment of our technologies, ability to reduce readmission rates, to significantly reduce the amount of time clinicians need to spend with patients, both in primary and secondary care, reducing interactions, telephone calls, and consultant time. We've also had very positive response in terms of patient feedback. 90% adherence in all age groups, 18 to 85. We've had extremely positive feedback on the ease of use, usability of the app. And also very positive feedback in terms of the patient engaging with the remote care service. We've also had good feedback in terms of ability of clinical teams to spot deterioration, and that's been particularly evident within the COVID wards, but also within being able to spot patients that are deteriorating on surgical wait lists. So hopefully that's a useful overview. Of course, happy to answer any questions, and my colleague Karanjit will also be in the breakout area later to further address any queries or questions that may come. Thank you.
Good afternoon, everybody. It's Robert Hepburn standing in for John Griffiths.
I beg your pardon, sorry.
You're very welcome. Right, so the first slide really doesn't need a great deal of introduction. Clearly, why we feel we're number one is that we provide the foundations also for others to create their own pathways as well as ourselves. We're the UK's number one choice for digital health and remote patient monitoring. Our clients now include more than 50 NHS organisations. We run over 100 pathways on our platform, and we're reaching over 50,000 patients per year and delivering huge efficiencies to more than 2,500 clinicians. Some of our individual pathways have delivered astonishing results so far, including saving over 100,000 outpatient appointments via our INR service in the North East. We've reduced home visits by over 90% and waiting times by 66% for the dietetic team in Northern Ireland who implemented our under-nutrition service. Some of the other pathways we've enabled across the country include the digital care home service, which coordinates the monitoring of blood pressure, temperature, weight, heart rate, CO2, SpO2, and risk of undernutrition. The service acts, frankly, as an early warning system, so it highlights changes in health which may otherwise go unnoticed. Our falls prevention service highlights most at risk from a fall, and patients send a series of questions around how they're feeling, if they've experienced any dizziness, and if they've had any falls, how they're doing, and how they're getting along with their exercise plans. What we've noticed here again is that user experience is key, and we've built that into all of our pathway. Next slide, please. Right, I won't talk over this slide too much. It's just a sample. As well as these individual services, mostly our platform projects allow us to help us train service providers and help them deliver the key pathway that would suit their region. Next slide, please. And I'd also like to introduce my colleague, Amy Frith.
Hi, everybody. So my name's Amy. I'm an account manager in healthcare, and I was lucky enough to be part of the team that worked with the Wessex AHSN, and we rolled out a COVID Oximetry at home service. And as you can see there, we went live in a lot of areas in a very quick space of time. So it's very busy for everybody involved, but we managed to roll it out fairly quickly, and there's a few more areas still to go live. Can I have the next slide, please? Thank you. So working with the team sort of well before Christmas, they that their main issue was the silent hypoxia, which of course we all know about that. And they needed something in place quickly to help monitor these patients, keep them out of hospital. So what they did was created 7 hubs across Hampshire and Isle of Wight, and they allowed patients to use whichever communication methods they wanted to, whether it be SMS, automated telephone call, or online. From there, patients were monitored between 10 to 14 days, and clinicians were alerted as and when patients went out of thresholds. So it could have been that they could also change the thresholds to be patient specific. So if they knew the patients already, they could change those to be patient specific, and so that if that patient, for example, always had a high SpO2 rating, then they could change that so it wouldn't alert all the time. And with this, we also had the where you could see directly, once you logged in, you could see if the patients were flagging as green or red, so you could see immediately which patients need to be contacted urgently or sent to hospital. So I think that's it for me. I'll pass back to Robert.
Thank you, Amy. Right, CHCP is one of our partners in the Yorkshire and Humber region. CHCP have developed with us the appointment screening app, and actually the success of it is, well, frankly, in the statistics. So we save 2,000 appointments a day, patients confirming if they'd had their symptoms prior to their appointments. This saved a nurse having to ring every single patient every day. To give you an idea, that would have been 350,000 calls between March and November. Next slide, please. Pre-endoscopy. So endoscopies are widely perceived by patients as uncomfortable procedures, and in essence, everything we try and do in healthcare is based around patient focus. So working with another partner of ours, Olympus, we've been able to create a digital education solution. They found the majority of patients were attending their appointments without sufficient preparation, despite the fact that they were being sent reams of paper to sort of study in advance. They're used in healthcare to allow the patients to complete pre-appointment assessments and triage themselves actually for what pre-assessment was required and whether they needed more or less of tailored education. And that helped them because at the most appropriate time they were getting the right easy to use information. Next slide, please. So on this slide here, we allow care home staff to collect soft signs and vital signs readings from residents using the InHealthcare app. The app triages these readings and presents care home staff with advice on how to care for that patient. Those readings are also passed through to the GP, who can keep a closer eye on care home residents remotely, saving a great deal of time and again efficiency. Next slide, please. Long COVID is something that we're working with several partners on at the moment. Obviously, everybody is trying to understand long COVID better and where the outcomes might be. But as you can see here, we've got most of the key elements that we are particularly working on, the vital sign measurements. And again, it's going to be supporting those patients as we get through the remainder of the crisis. Next slide, please. And who trusts us with their digital health projects? Again, I shouldn't talk over this too much, but give you a moment to study it. But again, our experience, the fact that we're working with the NHS very proudly and developing new pathways all the time, I think that gives everybody an indication of just how successful in healthcare is and actually how seriously we take developing products that can serve the industry better. And thank you. Thanks for listening, and we'll be in the chat room for questions later.
Hi, nice to meet you all, even though I can't see you, but my name's Louise Huff. I'm the Customer Success Manager from Current Health. Just want to give you an overview discussion about Current Health and share some of the expertise and the hospitals and use cases. So Current Health, we are a remote patient platform, so we monitor patients remotely continuously, and already within the Eastern of England we are working with Norfolk and Norwich looking after oncology patients, monitoring neutropenic sepsis, but also more recently with COVID, working with a number of NHS trusts to track patients rather than admit them to hospital, but to manage their care in the home. So what we do is offer a safe alternative to the management of patients in hospital. And a number of other chronic diseases that we manage at home, such as chronic heart failure, COPD. Next slide, please. So basically, in addition, we've been doing some work down at Imperial College Hospital looking at frailty, and now getting more involved with more complex patients, and the same with Croydon. So I mean, this is just to give you a bit of a flavour of some of the use cases and how remote patient monitoring can be used to support patients in their own home. Next slide. So in Norfolk, one of the first patients that we started to manage were patients who were receiving intravenous antibiotics at home. And what this allowed was for patients who received their treatment at home, but also with continuous monitoring, detect any complications such as increase in temperature that could basically mean that the patient's therapy wasn't optimized. And the case study that we wrote as a result of this allowed the patient to stay at home and a clinical discussion to take place without the patient needing to come into hospital, because of vital signs data and blood analysis data being available readily for the clinical team. Thank you. Another example at Croydon. So we've been doing a lot of work at Croydon in a number of different clinical conditions, supporting patients with COPD and heart failure primarily, but in recent months have been working to support a lot of their COVID positive patients referred via the ED department. And in that time, 109 hospital admissions were avoided and over 1,000 bed days saved. And that's really in a 4-month period, which I think is just a real testament to how important remote patient monitoring can be, and how the platform can support clinical teams to be able to make decisions about when to bring the patient into hospital. And for the COVID patients, actually less than 1% of patients were admitted, which again is really fantastic news, because previously they'd have all been admitted. Thank you. So what do we offer? So it's a very simple patient experience, and really takes only about 5 minutes to set up. And so we give patients a complete kit, so everything they need. So home hubs to allow them to have Wi-Fi connectivity. We don't expect them to have the internet. The wearable device that's worn on their arm to gather the vital signs, and also the tablet to allow patients to complete tasks, but also for video consultations to take place between healthcare professionals and the patient. Thank you. And so the aim is, because in the US particularly, patients will set themselves up, they'll receive their kit and they'll go through the steps. So the tablet has a number of functions. So initially it guides them through the process from start to finish. At the end of the process, it then becomes a task list, explaining the tasks that have been set by their clinical teams based on their clinical condition that's being monitored. That also is a communication tool, not just for video consultations, but allows the patient to send a free text message back to their clinical team. Thank you. So our patients are really at the centre of everything we do, and they are the priority. And whilst we never meet the patients directly, patients are selected suitable by the clinical teams, and our role is obviously to ensure that they have the kit that they need, but that we, and particularly myself, support NHS customers and clinical teams to ensure that the patients are gaining the best out of the experience of being monitored at home. So the monitoring from the data and the thousands of hours of data that we have, and we are able to monitor the patient adherence, which currently stands at about 90%. And the feedback from patients is that they actually feel very reassured to know that they are being monitored at home, and the clinical teams can check in with them at any time. Thank you. So the monitoring, as you see here, the patient sat in the middle with the wearable device on their arm. At the moment, that wearable device is connected via a strap, but as we continue to enhance it further, it will be an adhesive connection to the arm, and basically using infrared light penetrating through the skin and tissue to the microvascular bed. Data is extracted, and that data, using artificial intelligence, is then converted to vital signs. Thank you. So the vital signs that we collect: respiration rate, oxygen saturation, mobility and step count, pulse rate, and body temperature. And body temperature is just a guide, but the device is CE marked. It's regulatory, has regulatory approval for the UK, so it's an ICU level accurate way of monitoring vital signs in the patient's home. And the Wi-Fi connection we will provide, as I said earlier, the home hub so that the patients can have everything provided through Current Health. Thank you. In addition to the wearable, we are partnering with other companies who provide Bluetooth enabled pieces of kit to complement the platform. So continuous glucose monitoring we will be offering probably halfway through the year. We already can monitor the axillary temperature. We can complete spirometry, BP readings and weight, so which allows us therefore to configure the kit depending on the clinical needs of the patient. Thank you. In addition to the tablet being a list of tasks for patients to complete, then we can also set up surveys for patients. So the survey, if it's a clinical survey, then that would be decided by the clinical team. And if it was a survey, friends and family test, then that's just loaded directly onto their tablet. Thank you. And video calls can be scheduled, or ad hoc video calls with the patients. Thanks. And all of this information is then held within a dashboard, and all healthcare professionals will have access to that dashboard to be able to check on the progress and any alarm notifications that are sent through to the dashboard at an individual patient level. Thanks. So just a little bit about Imperial: 80%, 87% reduction in admissions. And of course, if you don't admit patients, there are financial savings for the NHS. Thanks. This final slide, just to say, really, these are what the patients thought. This is a pre and post-op orthopaedic service managing patients with fractures pre-operatively at home, in for hospital, then back home post-operatively, being monitored, and just some of the feedback from patients. Thank you very much.
Thank you so much, Louise, and apologies, there's some gremlins somewhere clearly in the system, and thank you for making the time to attend, and thank you to those colleagues who've already been on the call and now left, because I know you have another important call to join. So thank you so much, and we'll be in touch.
Thank you. Bye now.
Thank you. And so may I now hand over to colleagues from Dokla. Thank you very much.
Hello everybody, my name is Dennis. I'm going to do you all a favour and leave my camera switched off, partly because I'm not that photogenic, but mainly because I live in a part of the country where the broadband is still provided over wet string, so if I put my camera on you'll probably lose my voice, I imagine. I represent Dokla, which was a company founded in Sweden specifically to develop remote patient monitoring services, and we tend to provide monitoring as a complete end-to-end service rather than simply providing monitoring software. So I'll focus more on the practical aspects rather than the technical in what I talk about today. Next slide, please. So in the UK, we have a number of projects underway, both in acute settings and in acute community care. But as well as monitoring patients, we are also running a significant research study for NHS England, which is being hosted by NHS CCG. And that study is looking to establish the costs and benefits of remote monitoring for a variety of pathways. Initially, we are looking at recruiting up to 1,000 patients with heart heart and various other comorbidities. And what we're doing there is a non-interventional study where we will collect data from these patients remotely, and then we will analyze it retrospectively to see and determine the extent to which remote monitoring is able to predict unplanned admissions. We're doing that through the application of various data analytical techniques, and we're expecting to be able to report the findings from that study either towards the end of this year or early next. Next slide, please. So at Northampton General Hospital, by contrast, we have a service that's been monitoring patients for almost a year now. This was a service that was set up very rapidly in the first wave of the COVID pandemic. And what we're looking at there are vulnerable patients who would otherwise definitely have been kept in hospital for monitoring. So the option to monitor them remotely has saved significant cost and freed up capacity. Interestingly, one benefit that we hadn't anticipated was that the service also allowed NGH staff who were themselves in self-isolation to monitor patients from home. So that was an interesting fringe benefit. The lead clinician at NGH, Fiona McCann, has produced a summary of the findings from the first few weeks of that implementation. So, Katrina, if it's possible, I'd like to forward that to you and see if you could perhaps arrange for it to be distributed.
Yeah, I'm sure that's absolutely fine. Thank you.
Okay. If we could move on to the next slide, please. So this schematically summarizes a typical technical setup. So on the left, we have the patient, and the patient connects to the service using a mobile phone, typically with an app. And in the projects we provide where we're looking after particularly critical patients, as Current Health do, we prefer to provide the phone as part of the service rather than letting the patient use their own phone, because we can remotely manage the phone, and that cuts down a lot on the sort of practical glitches that you get, particularly with patients who aren't quite sure how to use the technology. On the right-hand side, we have the clinician monitoring the patients, and they can do that from any device that can support a modern browser. And in the middle is the technical gubbins that makes it all happen. And we tend to treat that as a black box from a delivery point of view. So we take care of all of the hosting, all of the software configuration, any integration requirements. We look after all that so that the client can simply focus on their patients. Next slide, please. I think I mentioned in an earlier slide that we were software independent, and the one exception to that is that we do invest in the front-end app that the patients use, and the purpose for that really is simply to make sure that it is as absolutely easy as possible for the patient. The screenshots you can see here are illustrative. What the patient actually sees depends on the particular care pathway they're on. And of course, it can all be configured to suit local requirements. Next slide, please. A couple of the speakers have talked about continuous or real-time monitoring, and I just thought it might be worth to dig into that a little bit. By continuous monitoring, what we mean is that the patient wears a device that streams their data on a continuous basis to the service via a Bluetooth connection to a mobile phone, which is quite different from the use case in which a patient takes their own measurements and enters them into the app a few times a day. And of course, the main advantage of it is that the continuous data gives you the earliest possible indication of changes to a patient's condition. The disadvantages are that it is more expensive presently, though we would expect that to change as this type of technology becomes more commonplace. The devices themselves need recharging more frequently. And also, unless you take care about it, you can get a lot of false alarms where, for example, the patient's heart rate suddenly rises and you find it simply because they've walked up the stairs or whatever. But we're investing in software now that will filter out the noise from these continuous measurements and result in a greater focus on the clinically significant attributes of the data. So if we could perhaps move to the next slide, please. So naturally, there has been a huge amount of interest in remote monitoring for COVID, but remote monitoring has been around for quite a long time, and good software can support a very wide range of measurements. So we think that the scope to extend the use of remote monitoring to other pathways is very considerable. And indeed, a number of the earlier speakers have mentioned a range of other use cases, which we also are implementing in our projects. Next slide, please. Excuse me a moment. Just got a slight technical hitch. It might be useful just to have a quick word on devices. Clearly, if you are happy that the patient is capable of taking and entering their own devices, then you can use whatever devices you like. If you want the devices to be more closely integrated with the service so that they are picking up measurements automatically, then clearly you need to spend time testing that the devices will interoperate with your software correctly. We do all of that as part of the service we provide, and we are continually testing different device types to make sure that they interoperate successfully. Next slide, please. Perhaps the most important aspect, though, of remote monitoring is patient compliance. So if the patient doesn't report the right information at the right time, then the whole basis of the service is undermined. So with that in mind, when we implement remote monitoring, we tend to provide a complete end-to-end service that includes the support of the patient by our staff. So we monitor their compliance the whole time, and we contact them if they're not submitting the data we expect when we expect it. And that allows us to achieve very high levels of compliance, which in practice tend to be over 95%. And we can also take on all the logistics of distributing and retrieving the devices from patients. So finally, the last slide, we should say that patients are overwhelmingly positive about remote monitoring. Our experience is that patients don't like to be in hospital for obvious reasons, and at the same time, they don't like to be left alone at home without being monitored. And remote patient monitoring gives them the best of both worlds because they have hospital level monitoring while they're at home. And I think the examples on the slide there, to the left, we see a letter that's been sent into a local Northampton paper by a very grateful patient. And to the right, you can see typical feedback from a patient survey. I think one of the comments from a patient was that they think remote monitoring is the future of healthcare, and I certainly support that. Right, thank you. That's all I wanted to say. I will be in one of the breakout rooms.
That's super, Dennis. Thank you so much. Again, another useful and informative presentation. And now we're on time, so let's crack on. So we now may introduce Wizan and may introduce Keith to you all. Thank you.
Hello everyone, I'm Keith Chessel. I'm the CEO of Solcom Limited. We've got a range of products which we call Wizan. I'll tell you about them. So at the centre of Wizan, there's a cloud-based triaging dashboard that can group patients into CCGs, PCNs, GP surgeries and care homes. And feeding that dashboard, we've got multiple systems. So we've got our blue box system, which is a self-contained unit that's used in more than 2,000 care homes. It can calculate the News 2 score and do soft signs. It's also used for people post-hospital discharge and with long-term conditions at home. Domiciliary care companies and community teams carry their kit around, and they also can monitor patients that are at high risk or people that have been discharged from hospital. Next, we've got our free application, which is being used in pulse oximetry, but can be used in multiple other regions, and I'll talk about this next in a moment. It also supports an informal care network, so a user of the app can share their data with friends and family carers. And then we've got our Guardian product, which monitors activities, physical activities of people in their own home, so their movements, the door openings, GPS location, whether they're turning on the kettle, opening the fridge. So with these three things, you can actually monitor someone's health and activity, and that's particularly important after, say, a hospital discharge, where you can see that, are they moving about? If they are moving up and down, well, then we perhaps don't need the full care package that you planned. In terms of interoperability, we've got our NHS FHIR interface, FHIR interface, and we shortly have an interface to 111, and that would mean that a high news score in a care home will trigger a 111 event, and the 111 team will phone the care home. Okay, next slide, please. A little bit more about Blue Box. So as standard, it comes with pulse ox, a BP monitor and thermometer. There's a tablet PC that supports a whole range of assessment tools that you can see. I'd forgotten on the list, it also supports COPD and heart failure assessment tools. We can link to that with multiple instruments, including stethoscopes and ECGs. We're not hardware dependent, so we're agnostic to that. And the device can talk back through Wi-Fi or 4G or whatever connection's there. Just this little note about Essex. So Blue Box does keep people out of hospital. We're getting data from Essex, who've rolled it out into now 300 homes, but in 200 care homes, they made an equivalent saving of 800,000, which, you know, gives a return on investment down to just a few days. Next slide, please. So I wanted to show you this. This is our free application. It's totally free. We've contracted with CCGs to provide it for a year with an option to renew, all totally free. In this app, it's a dynamically reconfiguring app. And the way it works is you create a folder, topic folder, say COPD on the Wazan dashboard. You upload multimedia information, so that could be anything from videos about how to take your inhaler, music to calm you down, questionnaires, exercises, links to other websites. Then you add your patient, you share them a web link, and they can load the app on whatever device they've got that supports a browser. And then you can actually select which topics and subparts that patient will see. So you can pick the inhalers that they use, you could pick the exercise routines that they are appropriate to their stage of disease, and you can add vital signs. The system has a weather forecast with air quality index as well, so that's quite good for COPD, and the data goes to the dashboard as per the Blue Box and create alerts and form part of the triage. Next slide, please. So here I'm showing you some slides, some screenshots for its use, current use in pulse oximetry. Everything about the screens were configurable, so the colours, the messages, the order of which things are shown are all configurable from the dashboard. And if you had a patient that you needed to take their blood pressure as well as pulse oximetry, you'd go to the dashboard and you just click into their case and change the setting and add a BP monitor, and that part of the app would update for that person, and they would then see BP monitor as part of their vital signs. NHS I like using it for osteoporosis. They're using a QR code on a poster. If a user points their phone to the QR code, they get the app, initial part of the app, so that's before they register. The app is a questionnaire at that stage. They see a questionnaire about why they're in a fracture clinic, and if it turns out that they're over 50 and they conform to certain conditions and they've broken their arm, perhaps unexpectedly, then the app will invite them to register and they'll get a referral through to the osteoporosis team. So it's a very versatile basis to create applications for multiple diseases, and we are keen to work with other NHS regions and for other disease conditions. The app also comes with free technical support. Sorry, that was me done. Thank you. And I'll be in the breakout session if anyone wants to talk to me. Thanks.
No, that's great, Keith. Again, thank you very much. And we've actually finished ahead of time. Goodness me. Well done, everybody. That's a congratulatory pat on the back for everybody. So as you would have received the original invite, this meeting was originally meant to run until hour, but I'm just going to do a little quick plug. If those of you that are able to stay, our presenters have very kindly been able to sort of go away and come back again, or have stayed on the call, and we have managed to manipulate the technology so we can actually operate breakout rooms. Some of you would have done this before successfully, some of you may have done it unsuccessfully. Fingers crossed we'll be absolutely fine. So just while that slides up on the screen there, just to share that we have 6 breakout rooms, but what we need to ask you to do, if you're able to stay on and if you'd like to stay on, and if there's a particular presenter, or if you'd like to speak to Andy in room 6, unfortunately we weren't able to design a logo quickly enough for him. If you'd like to have a chat with any of our colleagues, what you need to do is just put your name in the chat function down the side, and then by the wonders of technology, Tanya will be able to put you into a room, and you should be able to see in the top right of your screen the square that says join room. And once that's then been programmed in, you can then join that room and hopefully have a bit of a chat. We're not really sure how many people are going to stay on, so it's a little bit of a best intentions winging it, but we're going to give it a try over the next few minutes. And so by all means stay on if you can. So yes, if you're able to start putting your names in as we then move on to the next few slides, just to summarise, I think, where we need to get to. So previously colleagues have mentioned about the DPS, the dynamic purchasing system. Again, I'll admit, didn't know about this about a month ago myself, so I've had a little bit of a look around, known as the Spark DPS list, and this is something that obviously looks as if it's being updated. It's a very live conversation. People are joining, companies are joining this list very frequently, but it's there to support procurement process, to make it, those of you that have been involved in procurement before know it can be quite a tricky one to navigate. So there are companies on there that you can go and look at your leisure to see who's registered. And then just moving on, if I may, just to plug then also, some of you will have experience of NHS Futures and hopefully have a login for some of the COVID Oximetry work and other specialties too. Also then there is an NHS X blueprint page, which again has been developed and is in development. There's an awful lot of information there. There's case studies, there's some really in-depth implementation toolkits, how people have really understood the nitty-gritty, what the challenges have been, and what the successes of implementing these programs are. So again, there's a bit of a plug. If you don't have an NHS Futures website, by all means click on that link. You can then join and ask to join that workspace if you currently aren't a member. So again, something to look through and have a look at what is a very evolving library and a good resource to access for remote monitoring expertise. So I think that's all I'd like to say at the moment. So if we can then just move on to the next slide. So again, thank you so much. This was not a little lastminute.com. We did have lots of interest. It was about being hopefully providing you all with something that new that you've learned, something that you knew already, and maybe have some questions which we will hopefully deal with in the breakout rooms. And thank you so much. If we don't see you again, hope to be in touch. And as I say, get in touch if you think you have any questions that haven't been answered today. Thank you so much.